I would like to thank the organizers for inviting me to give this talk on SpaceOAR Hydrogel for prostate cancer. Today, we'll briefly discuss an overview of prostate cancer, including anatomy, statistics, diagnosis, and treatment options, overview of radiation treatment, and then finally, how SpaceOAR Hydrogel is incorporated into the treatment paradigm for men with prostate cancer undergoing radiation treatment. The prostate is a gland in the pelvis of a man surrounded by the bladder and the rectum. As can be seen here from a side view of the patient, the bladder sits on top of the prostate, from which a urethra, or the tube which men urinate from, goes through the prostate gland itself. Behind the prostate sits the rectum, and these are where the potential side effects from treatment of prostate cancer can arise. So how do we diagnose prostate cancer? First of all, screening is a tool where detection occurs in a patient without symptoms. This can take the form of a PSA, or prostate-specific antigen, which is a blood test. If the PSA is elevated, it may lead the physician to undergo further tests to explore the reason for the increase in PSA, including prostate cancer. A physical exam can also be performed, called a digital rectal exam, where the prostate is examined by the physician to check for any irregularities. Non-screen detected prostate cancer occurs when a patient is diagnosed during the work of symptoms, including pain, urinary obstruction, or bleeding. And finally, the only way to confirm the existence and severity of prostate cancer is for men to undergo a prostate biopsy. There are two main methods in which a prostate biopsy can be performed. One is a transperineal approach, and one is a transrectal approach. In the transperineal approach, the prostate biopsy needle is guided above the rectum, below the scrotum, and not actually through the rectum. This can potentially allow for anterior lesions and lesions that may not be approachable from a transrectal approach. The more traditional way to biopsy prostate cancer is the transrectal approach, where a probe is inserted into the rectum and then the prostate is biopsied from that angle. So how do we determine the severity or the aggressiveness of prostate cancer? One is grading and staging, and this is the key pillar for prostate cancer that has not spread or metastasized. Gleason score, or grade group, is one of the key pillars of stratifying the risk of prostate cancer. Gleason score occurs on a scale of 6 to 10, with 6 being more indolent of a cancer and 10 being a higher grade of cancer. Similarly, to simplify grading of prostate cancer, a grade group definition has evolved, where it ranges from grade 1 to grade 5. Similarly to Gleason score, grade 1 is considered more of an indolent form of prostate cancer, while grade 5 is considered more aggressive. Additionally, T-stage, or tumor stage, is also incorporated into the staging of prostate cancer. This can be determined through imaging, such as MRI, or clinical exam results to estimate the extent of the tumors and whether it is confined to the prostate or potentially has gone outside of the prostate capsule. Similarly, as we mentioned before, the PSA test, or the PSA value that is derived from a blood test, is also important in staging the prostate in a man's prostate cancer. Other factors that come into play when deciding on the degree and extent of prostate cancer at new diagnosis include the velocity of the PSA, in other words, how slow or fast is it rising, various genomic tests that can be performed on the prostate cancer biopsy, therefore giving us more granular information on the severity of the disease, the volume of tumor that can be seen through either advanced MRI or PET imaging, and additional risk assessment tools and laboratory values that can help us understand the grade and stage and potential aggressiveness of the prostate cancer. So there are many common treatment options for men with prostate cancer, including active surveillance, surgery, or radiation treatment. Important to know that all modalities are potentially options for men with newly diagnosed prostate cancer. The key for each patient is to understand the risk and potential side effects of undergoing treatment or not undergoing treatment. First, we'll focus on active surveillance. As I mentioned before, because prostate cancer often grows very slowly, some men, especially those that may be older or have other health problems, may actually never need treatment for their prostate cancer. Instead, physicians may recommend approaches known as active surveillance or watchful waiting. What happens here is that men are closely followed for symptoms or upgrading on either PSA or imaging to decide when an intervention may be necessary for that patient. Definitive treatments for prostate cancer include surgery and radiation treatment. Surgery may be performed through what's called a prostatectomy or surgical removal of the prostate, also known as a radical prostatectomy. This may be done laparoscopically or by the assistance of a robot called robotic-assisted laparoscopic radical prostatectomy. Radiation treatment can also be performed for men with prostate cancer, and the methods include 3D conformal radiation treatment, intensity modulated radiation treatment, stereotactic body radiotherapy, brachytherapy, or proton. It is important to discuss with your treating physician which modality may best serve you or which options are available to you. Throughout all of these modalities, whether it's active surveillance, surgery, or radiation treatment, it's important to have that conversation with your urologist, radiation oncologist, and perhaps medical oncologist, and the treatment team that will be taking care of you for your prostate cancer. So now we will move into the treatment overview of radiation therapy. So radiation is using high-dose radioactive exposure, such as high-energy X-rays. And the purpose of this is to kill cancer cells in order to treat prostate cancer. However, separated only by a very small space, radiation can unintentionally cause damage to the surrounding rectum, as we touched upon earlier. Possible side effects of radiation treatment include bowel irregularity or dysfunction, which can be associated with loose stools, diarrhea, blood in the stool, or rectal leakage, and also urinary dysfunction, which includes urinary frequency and urgency. In other words, the need to urinate more often, have a burning sensation while you urinate, blood in your urine, or potentially urinary incontinence, which is the inability to hold your urine. The different types of therapeutic radiation treatment include, broadly speaking, external beam radiation treatment and internal beam radiation treatment. External beam comes with a laundry list of different and confusing names for patients. One includes 3D conformal radiation treatment, IMRT or intensity modulated radiation treatment, image guided radiation treatment or IGRT, stereotactic radiation treatment, which is also known as SBRT, or proton therapy. Broadly speaking, most practitioners will use IMRT and IGRT incorporated. In other words, we will modulate and deliver the dose accurately through image guidance. Stereotactic body radiotherapy generally involves treatment sessions of 5 fractions or 5 treatments or less. Proton therapy is a different type of treatment where a different type of particle is used in order to treat prostate cancer. For internal beam radiation treatment is generally known as brachytherapy. And brachytherapy generally involves either low-dose implants, high-dose implants, or potentially permanent implants. And what happens here is rather than the external beam radiation source coming from outside the patient's body, seeds or catheters are placed within the prostate to deliver the radiation dose. Again, it is important to discuss with your practitioner as to which of these modalities may best serve you best and understand your treatment options before deciding on which course of radiation treatment to undergo. Now, one of the issues with radiation is potential for toxicity to neighboring organs. What we are seeing here on this slide is a CAT scan of a patient, both from what's considered an axial view or looking at the patient as if they're a loaf of bread and taking slices of them. And on the right side, we see what's considered a sagittal view or looking at the patient from the side of their body. What you can see in the diagram here on the left is the prostate encircled by the red bands, and the shades of color that are expanding from it are the radiation dose that's being slightly lower than that delivered to the prostate gland itself. As you can see, the rectum is abutting the prostate and therefore receiving potentially some high dose and lower dose of radiation. Similarly, on the sagittal view or on the right side of your screen, you can see the side of the patient. Again, you can see how close the rectum sits next to the prostate and where the bladder sits right on top of the prostate, and therefore minimizing any strategy to minimize dose to these organs potentially limits any side effects or toxicity from radiation treatment while still being delivered with a curative intent. Now, what does rectal toxicity look like in the real world? This study was a retrospective analysis entitled Early Tolerance and Tumor Control Outcomes with High-Dose Ultra-Hypofractionated Radiation Therapy for Prostate Cancer, also known as SBRT, or stereotactic body radiation treatment, where a total of 551 patients with prostate cancer received what is considered high-dose or dose-escalated SBRT to 40 gray of radiation over 5 fractions or 5 treatments. 269 of the 551 patients underwent placement of a hydrogel spacer. As can be seen on the graph on the right, the percentage of the late toxicities with and without spacer are quite different. From a gastrointestinal or rectal toxicity standpoint, you can see that no hydrogel spacer led to a 6% late toxicity rate compared to 1%. Similarly and remarkably, the genitourinary or urinary side effect profile was also minimized by the insertion of a rectal spacer or the SpaceOARTM hydrogel from 32% without a rectal spacer down to 15%. And therefore, the authors concluded the use of a hydrogel rectal spacer was significantly associated with reduced late GI toxicity and lower odds of developing late GU toxicity. So why rectal SpaceOARTM hydrogel? So as we've alluded to, rectal irradiation is often unavoidable just given the proximity of the rectum to the prostate. Additionally, the prostate could move between treatments and during the treatment, and the rectal spacer may act as a fixative in order to limit this motion. And again, during the treatment, while the patient is on the table undergoing radiation treatment, this could limit what is considered intra-treatment motion while the patient is undergoing radiation treatment. So the rectum is considered an organ at risk, or an OAR, for receiving unintended radiation. As we mentioned earlier, rectal toxicity, side effects, and complications can be seen for men undergoing radiation treatment for prostate cancer, including bleeding, frequency, urgency, pain, and fistulas. As you can see on the right, the radiation dose around the prostate can abut the rectum and therefore potentially lead to these side effects, which can significantly impact the quality of life. Radiation injury can lead to bowel, urinary, and sexual symptoms that can affect patient health and quality of life during radiation treatment and for several years afterwards. Now, the benefit of hydrogel spacer is that it temporarily positions the rectum away from the prostate. It is designed to reduce rectal wall radiation exposure, as clearly demonstrated on the graphic on the right. It is inserted via brief outpatient procedure that usually lasts about 10 to 15 minutes. And after about 6 months, the SpaceOAR rectal hydrogel is naturally absorbed and removed through the urine. It is composed of a synthetic, biocompatible, non-toxic material. As mentioned earlier, it is absorbed in approximately 6 months. It is made of mostly water and polyethylene glycol, which can be seen in many medical products, including artificial tears, prescription drugs, and medical implants. The procedure, as I mentioned, is a brief outpatient procedure, and your practitioner may use local, regional, or general anesthesia based upon their practice. In multiple clinical studies, SpaceOAR hydrogel is designed to provide space between the rectum and the prostate, reducing high-dose radiation to the rectum. Control patients were 8 times more likely to have a decline in bowel, urinary, and sexual quality of life domains when compared to SpaceOAR hydrogel patients at a median of 3 years. So what do the clinical results tell us? More space equals fewer rectal complications, fewer urinary complications, fewer sexual complications, and therefore yielding a higher quality of life. As mentioned earlier, patients were 8 times more likely to have a decline in all of these domains compared to patients that had the SpaceOAR hydrogel at a median of 3 years. So what are the numbers of the use of SpaceOAR hydrogel? There's been over 75 peer-reviewed publications. It's used in many, if not all, the leading cancer centers in the United States. It is reimbursed by Medicare and a growing number of insurance companies, and greater than 50,000 patients worldwide have been treated using rectal SpaceOAR hydrogel. So I'd like to thank everyone again for the opportunity to discuss prostate cancer, treatment options, and the use of rectal SpaceOAR hydrogel in the paradigm of men undergoing prostate cancer radiation treatment. And I encourage everyone to visit SpaceOAR.com for more resources, including SpaceOAR hydrogel physician locator, patient helpline, and educational material, and happy to take any questions.
Well, hello, I'm Ryan Terlecki. I'm a urologist from North Carolina at Atrium Health Wake Forest Baptist, and it's certainly my pleasure to be with you for this meeting. And I'll be speaking about life after prostate cancer, or what we refer to as prostate cancer survivorship. It's actually my area of focus, and I enjoy trying to get men back to where they were as close as possible before their lives were affected by prostate cancer. I certainly appreciate the opportunity to partner with ZERO, and I admire the work that they do for men that have been affected by this disease, and certainly anyone that's connected to them, whether it be loved ones or their providers. So this is actually going to be a 2-part discussion about some items that affect men after treatment for prostate cancer. So in the first part of this discussion, we're going to be explaining options for bladder health and what leads to some issues with continence after therapy, regardless if it's surgery, radiation, or any one of a number of modalities that's designed to eradicate cancer within the prostate. So setting expectations is always important, but for a lot of men that are attending this meeting, they may have already been treated for the disease itself. So regardless of whether the prostate itself has been removed or if it's been treated with radiation therapy, the tissue that prevents leakage in the normal situation flanks the prostate on both the top and the bottom. The area below the prostate, which in this cartoon is labeled the sphincter, is the more important section of control. So the urethra itself, which is the tube that drains the bladder and allows the urine to empty to the outside world, starts within the center of the prostate. So this first segment of the urethra is entirely removed if someone undergoes a radical prostatectomy for cancer, and then the bladder is then brought down and secured to the urethra with suture. With time, most patients are going to recover control, but definitions about what it means to be dry can vary. In some cases, using a single pad per day for leakage may still be considered dry. However, men with this issue can tell you that any amount of incontinence can lower their quality of life. Now, we refer to the type of leakage that typically happens after prostate cancer therapy as stress urinary incontinence. So that's what that abbreviation is on the lower portion of the slide. So this refers to the type of leakage that happens when any type of abdominal stress is applied to the outside of the bladder. So coughing, sneezing, lifting something heavy. If that type of pressure causes one to lose some degree of control, again, that's stress incontinence, and that's what we're going to be speaking to over the next several slides. So I think it's important that if you have this issue, that you know that you are not alone. Each man is certainly unique and each treatment is personalized, but the struggle itself is shared. This slide cites a 10-year-old paper from Italy that looked at a collection of prior publications to kind of give an overall average on the rates of leakage. But in some of the studies that were included, that rate of incontinence was nearly 50%. So you can see that there's clearly a range. But regardless, if this affects you, we're here for you and you have options. So for mild to, somewhat in the range of moderate leakage, if someone is more interested in just managing it rather than having it corrected, there's a variety of options out there. Pads and diapers are certainly available for purchase, but the cost can add up and they can be somewhat cumbersome, somewhat annoying. Condom catheters, which is what that cartoon to the right of the slide represents, are an option as well, but they're not always reliable as far as staying in place. Penile clamps, which you see pictured in the lower cartoon, despite the use of foam material on the interior, can be somewhat cumbersome and uncomfortable as well. Pelvic floor physical therapy, which does often include things like Kegel exercises, but is actually much more comprehensive in terms of an overall program, doesn't necessarily lower the rate of incontinence, but it can actually improve the timeline for recovery after surgery. And I think that's important for men to know, especially if they're in the early phase following their treatment. Now, as we move on to talk about options for higher degrees of incontinence, in this case, what we'll call moderate stress urinary incontinence, injections and bulking agents have been tried, but that's off-label use. We don't currently have an approved product for male incontinence to inject into the urethra to kind of bulk it up. Historically, that option has not been very effective. The male sling, however, is an excellent option if you select the patients appropriately. It's typically advertised for mild to moderate incontinence, and it certainly works well, in men that, can probably get by with 2 to 3 pads per day and at least have some degree of residual sphincter control. It's important to recognize that men who have undergone prior radiation might not respond as well to this line of therapy. However, it's an outpatient procedure. The material that you see on the slide and in that cartoon above it is actually going up under the urethra and acting similar to a hammock, kind of giving it some extra support to minimize the chance for leakage. The nice thing about a procedure like this is the improvement is immediate. So following the procedure, you wake up, you're on your way, and you can already appreciate the benefit. And it's automatic. There's no need to push a button, nothing else for you to do. So it's been out for a while. There's been certainly some advancements in the technology over time, and men that are properly selected are certainly very happy following this procedure. Now, going back to the early 70s, the artificial urinary sphincter was created specifically for men who had stress incontinence after prostate cancer surgery. So this still remains the gold standard for men who have severe urinary incontinence. And it consists of 3 components that are working together as a system. They're all connected, it's all internal, it's self-contained, and it operates on fluid pressure that's mediated from saline within the device. So you have a urethral cuff, and I'll try to use the cursor here to see if you can see this, but essentially what this is, it's a circumferential water balloon that when it's full, exerts pressure to close the urethra. And that pressure is dictated by a small balloon that we refer to as the pressure regulating balloon. And a patient can neither see nor feel where this is located. But in order to be able to empty the bladder, there's a control pump about the size of an olive that's hidden inside the scrotum. So when someone has their bladder, telling them it's time to go, they reach down, they feel it, they push the button, and that cuff will open and give an appropriate amount of time for that patient to empty their bladder. And then it automatically goes back to full to give the control that you need when you go about your daily routine. So again, great option, has stood the test of time for decades. And for men that have significant degrees of incontinence, finding an expert well-versed in this type of operation is probably a really great option. So in terms of assessing one's conditioning, getting more information, of course, there are a variety of inventories, symptom scores, things that can be done. You can track your pad usage in a journal. Sometimes this provides valuable information when you go to see a urologist about getting this issue addressed. But if you're at home or on a mobile device, a great source of information is a website. That's fixincontinence.com. Once again, that's fixincontinence.com. You can get information, you can find a local provider and so forth. And then it allows you to kind of rate your incontinence. Is it mild? Is it moderate? Is it severe? And so you can get more detailed information as to what will suit you. Okay, so that's the first part. So we've addressed bladder health. Now we're going to move on to the second part, and an item that's important to numerous men, especially considering the age at which most men are treated these days with curative intent for their prostate cancer, is sexual health. So how does prostate cancer treatment affect sexual function? It's important to recognize that the prostate itself on each side is flanked by the nerves that dictate the signaling into the blood supply for the penis for erectile function. So those nerves can be affected not only by surgery, but also by radiation and a variety of other therapies that are used by those providers treating prostate cancer. The people that regain some degree of function typically do so during the first year after treatment, but there are a few gentlemen that will see continued improvement between years 1 and 2. Now, the strategy or the concept of penile rehabilitation is largely based on animal studies, and one of the leading proponents of this concept is out of New York, and they continue to study this, but there was even a paper published from that center in February of 2021, where they assert that the data is still not there. So they continue to try to see if they can develop a program that will help men get closer to where they were before therapy. However, if a man does not recover satisfactory function after surgery, after radiation, after what have you, we have effective options available for them. So these treatment options vary. And so some of these are, certainly, publicized. Men are well familiar with oral medications. Viagra was the big one, the chemical name being sildenafil. And later we had drugs like Cialis or tadalafil. Now, sometimes those medications are even being used before treatment because the majority of men after the age of 40 do see a slight decrease in function as they've aged. Now, these may or may not be effective after treatments for prostate cancer, and they largely depend on the intact nature of the nerves that allows the signaling to send more blood flow into those chambers. The vacuum pump or vacuum erection device is pictured in the upper right of this slide, but this is something that you can now purchase on your own. You don't need a prescription to do so. They range in price, but they're easily available online. What happens is the chamber goes over the penis, and in the more modern versions, there's a battery inside that, with the push of a button, will evacuate the air, so causing blood to be pulled in manually into the tissue. But in order to take that tube away and to keep that pressure that's being provided by the blood within the tissue, you have to deploy a constriction band at the base of the penis. And there's a time limit as to how long that can stay in place. There are, pros and cons to this approach. It is somewhat cumbersome. The quality of the erection is somewhat less than what you would see naturally, or with some of the options we'll talk about in a second. The temperature can be a little bit cooler than natural, and the constriction band can be uncomfortable. So I would say the satisfaction rating among patients for this modality is mediocre at best. Moving beyond this, we have injections. And so, the concept of, using even a small needle to place medication into a sensitive part of a man's anatomy can be daunting for some, a little bit of a put off, but for those men that are willing to try this, it is oftentimes very effective. Now, it doesn't work for everybody, and sometimes if the dose is too high, it can produce an erection that lasts for too long, and that's a separate issue that needs to be addressed acutely. The medication itself typically consists of 3 components put together by a compounding pharmacy. Partners sometimes can be put off by the concept of having to delay sexual activity to go through this process each and every time. So again, it's kind of a middle of the road option. Urethral suppositories, I find these to be rarely used. There's something called MUSE, M-U-S-E. It's an acronym. It stands for Medicated Urethral System for Erection, and it involves using a tiny plastic plunger that inserts a medicated pellet into the urethra, which, as I mentioned earlier, is a tube we urinate through, and then that drug is then absorbed through the wall of the urethra to end up in the erectile tissue to hopefully encourage an erection. And then finally, the last option list on this slide is that of the penile implant. Much like the sphincter, this has been around since the early 70s, and I'll talk about this in a little bit more detail. So similar to what we saw with the sphincter, you have multiple components that are all connected. Again, it operates on fluid pressure, just like a natural erection operates on fluid pressure. And once it's in the body, it's therefore body temperature. So originally you had an erection that was created by body temperature fluid in the form of blood. This time it's body temperature fluid in the form of saline. So you have individualized liners of those 2 erectile tissue chambers, and then a fluid transfer mechanism, again, hidden in the scrotum. And so when a man wants an erection, he can put it up and then keep it up for as long as he and his partner desire. And then when you want it to go down, it goes back down with the small tab that you see at the top of that scrotal pump. It is completely internal, so someone could change in a locker room or be with a partner, and there's nothing that you can see from the outside to suggest that this is there. It does allow spontaneity in the sense that if sexual activity is desired, you're ready whenever. And so the sensation is typically well preserved at the end of a man's anatomy, which is the most sensitive part and what's most valuable for enjoyment of sexual contact. So as we mentioned, in terms of following your progress after therapy as it relates to continence, you can do the same thing as it relates to your sexual health. So we have assessments for ED. We have symptom scores. Sometimes these are available in the office, but you can see these online as well. And similar to the Fix Incontinence website, there's another website known as edcure.org. Once again, that's edcure.org. You can find out information about treatment options, and you can also find an expert based on your location. So in terms of some frequently asked questions, one of which might be, well, how long does it take to achieve bladder control? And as we mentioned before, every man's journey is somewhat unique, so it varies from gentleman to gentleman. If someone is making steady progress as it relates to recovery following treatment, we'll continue to follow them until they plateau. However, if a man gets to the point that he's 6 months out, let's say, from surgery and he's having severe problems, we may choose to intervene at that point. Otherwise, it seems reasonable to watch men for up to a year after surgery. We discussed some of the varying rates in the literature, but citing those statistics after a man's been treated doesn't really change what his current situation may be. The next question on this list is one I hear about quite a bit, and it's why don't all men recover function after treatment? Or specifically, when one man comes in, why didn't I? And I think one of the important things to stress is when a treatment, whether it's surgery or whether it's radiation, has been standardized, the variable is really the patient, and everyone is unique in terms of their ability to recover and to heal after a therapy that's designed to eradicate some components of tissue. And in this case, you're targeting the cancer cells. So if someone's a smoker versus someone who isn't, someone's obese versus someone who isn't, diabetes, high blood pressure, and so forth, then their ability to get back to baseline could be impaired, different from those men. Now, In this particular slide, it says that 30% of men suffer from erectile dysfunction. Again, that was based on that same group we talked about earlier, where they're kind of combining data. However, if you look at data more recently from high volume centers in the United States, the rate of recovery for functional erections is only 39%. So the majority of men after prostatectomy, for example, will be expected to have ED. And I think that's important for men to know they're not alone. It's not something that they did. This is a byproduct of making sure that they're around, treating significant cancers. So to the last point, are penile implants covered by insurance? Well, for most of the patients that come in seeking one, yes, they are. Many commercial policies will cover them. Medicare typically covers this. You might see some regional variation. And so there are services available that if someone comes in and says, I would like to have my sexual function restored, can you do this for me? You can process their information to make sure they know up front before the procedure is provided. So here we see a couple of testimonials, and I think it's important to know that there are plenty of men out there willing to share their experience so that other men don't have to go along dealing with some of these maladies for as long. Roy is quoted here as a survivor and says, after 7 years with a male sling, I still find the pads in a suitcase or a jacket that I haven't worn. It would be hidden in the pocket somewhere. I laugh and think, thank goodness I don't wear these anymore. And it can certainly be life-changing to go from having incontinence to not, or at least having it be much more manageable so that you can go out and enjoy those activities that you like to do. Barry, another survivor, is quoted as saying, prostate cancer surgery left me both incontinent and with ED. After having the AUS surgery, I could go places again and do things socially without risk of embarrassment. Now that I didn't have the incontinence problem anymore, I was ready to deal with the ED. When I had the penile implant, I felt completely whole again. It's restored my confidence and restored my life. And again, that sense of wholeness is a very common descriptor among men that have had either or both of these conditions addressed. And it's important to recognize too, that in some situations, we can correct both simultaneously. Once again, there are resources. We mentioned the first two, fixincontinence.com and edcure.org. The American Cancer Society has a website at cancer.org. The Prostate Health Education Network, or PHEN, has prostatehealthed.org. And of course, ZERO, our sponsors who are dedicated to seeing the end of prostate cancer, are available at zerocancer.org. Just remember, these are just some take-home points that there are treatment options for every man. So in terms of sexual health and erectile restoration, it's a common situation, but we have a variety of treatment options, including the implant, which is a permanent long-term solution. As it relates to urinary control, incontinence can be effectively managed after therapy for prostate cancer. Certainly, if it lasts a year or more, permanent solutions should be considered to bring back your urinary control. In terms of your next steps, I would always suggest that men who are part of a couple to involve their partner in decision-making, but to talk to your provider, and that may be a primary care provider, could certainly involve your treating urologist or oncologist about solutions and getting you to where you want to be. I want to thank you for your attention. It's been a privilege and a pleasure to speak with you, and I wish you all the best.